really look like this. And I think the reality is that it's looked much more like this. There have been lots of twists and turns and pivots along the way. Get rid of this problem of having two screens. And I think, but I would say that every turn and twist along the way, I've learned just as much about sort of the things that have worked as from the things that haven't worked. I think what's driven me all along is my clinical passion for treating patients with heart failure. I think that's still at the very heart of what kind of gets me up in the morning. And I'm so grateful to have found a clinical home here. I couldn't speak more highly of the heart failure section. I feel like you guys are my clinical family away from home. I think, it's an incredible privilege to be sort of walking alongside some of our patients, some of the ups and downs. And to illustrate this, I just pulled one example. This is a patient I got to sort of meet and get to know over a few years. He actually had a pediatric heart transplant when he was age 6. And the donor at the time was age 8. And at the time, his family actually tried to reach out to the donor family to sort of connect after the transplant, and they had lost touch and couldn't sort of really connect. And then many years later, fast forward 20 years, he's now a medical student at HMS. And they finally got a chance to connect with his family. And he actually went to visit this mother whose 8-year-old heart he had. He brought his stethoscope and she got to listen to her little boy's heart 20 years later. And I think those are sort of stories that really just stick with you. And I think it's just an incredible privilege to be in this field. Now, the longer I'm in this field, the more I realize there's so many questions that we still have no answers for. So why do some people develop heart failure? Why others don't? Why do some people do poorly, even despite GDMT? Why do some people recover? We don't know. So this is sort of the typical trajectory that we envision, but every patient is different. So there's so many questions. And I think this is something I sort of realized late in fellowship and is really what motivated me to pursue a research career. And so I think my research passion really has focused on better understanding molecular pathways that lead to heart failure, but doing so through human studies and really with the patient at the center of it. And so in fellowship, I really realized that I wanted to learn more. I first started learning about population-based studies and really understanding who's at risk. And so spent some time at the Framingham Heart Study. And this is just one example of sort of how we can understand risk. So this was a study that we did looking at sex differences in cardiovascular biomarkers. And it turns out that men and women are incredibly different when we look at proteomic biomarkers of cardiovascular disease. And I think this perhaps lends a little bit of light into how we can understand sex differences that we see clinically manifest in men and women. I think the other part of it that I realized early on is that observational studies can only sort of teach us so much, and that I really wanted to delve deeper and be able to test hypotheses. And so that really spurred my interest in patient-oriented and translational studies. And so one example of that is we've, for example, looked at really deep physiologic phenotyping using cardiopulmonary exercise testing to better understand why some people feel so poorly when they have heart failure while others don't. And so what we showed, for example, is that, again, men and women with HFpEF are really, really different when we look at exercise physiology. Women have much stiffer blood vessels, they have a stiffer heart, they have a much steeper wedge pressure response to exercise. Why is that? We don't really know. And then the last piece is where I feel like this place has been such a fertile ground for potential collaborations. I think how we can understand disease mechanisms using human studies is really with intervention-based studies or with collaborations with basic and translational scientists to really figure out what are the disease mechanisms and how can we think about therapeutic targets in the future. And so I'll just highlight one example here. This was work that was in collaboration with Raj Malhotra at MGH at the time. And what we did at the top is we actually found that a specific protein called matrix GLA protein was associated with incident HFpEF, and it was associated with incident HFpEF over HFrEF. So I thought that was really sort of interesting because when you look at most biomarkers, a lot of things are associated with HFrEF and not that many things are associated with HFpEF. And so it turns out that MGP, this protein, actually is known to cause or to regulate vascular calcification. So we actually went into Raj's lab and he looked at MGB heterozygous mice. And what he found is that these mice also have increased arterial stiffness, and that is because of greater collagen deposition actually in the blood vessels. It has nothing to do with vascular calcification, which is sort of the initial hypothesis that we had. And it turns out that MGP is regulated with vitamin K dependent mechanisms. And so this is potentially a therapeutic target. So again, sort of illustrating how we can go across human studies really into experimental models to really try to better understand disease processes. So I would say that 10 years ago, this is what my lab looked like. It was just me and my laptop. And it's been really fantastic to grow the group. And this is the group today. And I would say that for me, it's been just as much about sort of the scientific journey as it has been about the people that surround me every day and that keep me sort of learning and stretching and really going in different research directions. And so I guess with that in mind, I would say that when I came to the BI a year ago, I knew that there was a really sort of rich history of basic science research. We know that Zolta Rani was the director of research here many years ago, and he's sort of one of the world's sort of best known experts in cardiac metabolism. Tony Rosenzweig was in this position previously, and all of you know Tony really as one of the world experts in sort of myocyte biology and really understanding pathologic and physiologic hypertrophy and responses to exercise. And then of course, all of you know Rob and his incredible work, really trying to understand human metabolism and some of the genetic underpinnings. And so I think what I want to do really moving forward is to really leverage and harness all of this rich expertise in basic science and this history, but really to do so looking forward over the next 5 to 10 years to really figure out how we can make cardiovascular research more translatable to clinical work. How do we sort of incorporate this? How do we figure out what directly applies to the patients that we're seeing in the clinic? And so I think with that in mind, this is sort of the roadmap that I wanted to kind of go through today. Number one, we'll do some basic sort of why cardiovascular research still matters today. And then I think I really wanted to spend some time thinking about our strengths. I think what came to mind for me was our strengths are really multidisciplinary science. I think there's so much work going on through the breadth of science. I think what we have as a strength is a really diverse ecosystem. And I think what actually I didn't even really truly realize until I put this presentation together is there's really an incredible dedication to mentorship and to really training the next generation of future leaders in medicine. So I think I hope to highlight all of these and then really provide potential initiatives and other things to really think about how we move this forward. I would say this is more of an open conversation and I'd love to connect after this if you have other ideas, other ways that we can sort of build upon this rich history. So this is sort of a very historical figure that I love. This was published in the New England Journal by Betsy Nabel and Eugene Brownwald at the 200th anniversary of New England Journal. And they sort of lent a historical perspective on how cardiovascular mortality has decreased over the last 70 years or so, and put sort of major findings or major advances in cardiovascular therapeutics and treatments on the same graph. And what I think is so interesting is that we've made huge headways, right? In 1970, I think the in-hospital mortality for someone coming in with an MI was something like 15 to 20%. That's incredible. We've made such strides in that regard. And I think the other thing that I thought was interesting is sort of this graph starts in 1950, and actually with ties to Framingham, the first generation was actually enrolled in 1948. So this sort of all started in the 1950s. Bill Cannell first coined the term factors of risk for cardiovascular disease and described blood pressure and cholesterol as the two sort of cardinal traditional risk factors in 1966. And so just think about how far we've come since in the last sort of 70 years. Now, despite all of these successes, I would say that heart disease still remains the #1 killer, of course, in both men and women. These are data from the CDC in 2019 shown in the navy blue bars, and then 2020 in the light blue. And you can see that actually heart disease mortality has increased from 2019 to 2020 by 4%. Our life expectancy overall has decreased. And so these are really important to keep at the front of mind. We know, of course, cancer is the #2 cause. And then in 2020, for the first time, COVID-19 is the #3 cause of death. Now, COVID-19, I think, is interesting. This was a study out of the US Collaborative Network. I think we're going to see a tsunami of cardiovascular disease post-COVID. What these investigators did is they looked at patients who were admitted with a COVID-19 diagnosis, and then they followed them for about 12 months afterwards to look at cardiovascular disease outcomes after the COVID-19 diagnosis. And this was a propensity score matched analysis. There were about 690,000 individuals that were cases and matched with propensity score matched with controls. And what you can see, this affects all of cardiology. So we have increased hazard ratio of stroke, increased risk of all types of arrhythmias, increased risk of myocarditis and heart failure, increased risk of cardiac arrest, cardiogenic shock, thrombotic disorders, vascular disease. So this really affects, I think, all of us. And we don't really know underlying disease mechanisms. I think there's a lot of research and motivation to try to better understand this. But I think cardiovascular disease in this context is probably only going to grow in terms of the problems that we face. Now, being a HFpEF cardiologist or excited about HFpEF, I think one of the huge advances is that we finally have positive trials in the last 2 years, right, after a litany of sort of negative or neutral trials. And this is, of course, in SGLT2 inhibitors. So this was the DELIVER trial that was just published, really showing that treatment with SGLT2 inhibitors in patients with HFpEF benefits. And so we're all really excited and moving forward with this. I would say that, again, in this context, it's important to take a step back. And how are we actually doing? When you look at DELIVER, even the one first positive clinical trial using dapagliflozin in HFpEF, 20% of patients still had a bad outcome at 3 years. That's incredible, right? This is not a good outcome. 20% all-cause mortality at 3 years. So we still have this sort of massive residual risk in patients with HFpEF. And I would argue that if you look at any cardiovascular clinical trial, even when we celebrate all of the good outcomes that we have with therapies, there's still a huge residual risk for us to work with. And so I think this is sort of the vision that I was thinking about for us going forward with respect to cardiovascular research. The vision is really to conduct impactful cardiovascular science centered around the health of our patients. And how do we do this on a daily basis? I'd love to be able to enable diverse and transformative discoveries within and across scientific disciplines in cardiology. And we want to leverage our strengths. And again, the strengths that I really see that are so apparent are really the breadth of multidisciplinary science and the depth of it, the caliber by which this is done here. I think the diverse ecosystem across the cardiology division is really breathtaking. And I think we've learned from our diversity, we've learned from different perspectives around the table, and really how to sort of foster that, I think is something I'd love to sort of think through. And then again, this sort of dedication to mentorship across all of the career stages, I think is something that all of you are so dedicated to, and how do we continue to support that? So I'll go through how are we doing? I think the numbers show us that we're doing incredibly well. We have over 50 faculty members. Among those 50 faculty members, we have about 300 publications in 2022 alone. I think this is just sort of staggering. Thank you to Supriya for sort of pulling this lit search. She actually looked up every single person here. 23 alone in Circulation, 8 in JACC, 5 in JAMA, 3 in New England Journal. So I think we're doing incredibly well by all of the metrics that we measure as we look at research productivity. We have over $83 million in sponsored research funding for presently ongoing grants, including over $38 million in NIH funding. I think what's incredible is that we have 10 K awards here, and I'll highlight that later in the talk as well. I think a ratio of 10 to whatever, 5 to 1 in terms of faculty members to K ratio is probably one of the highest that I've seen across any division. So I think that this is really quite incredible. Now, beyond just the numbers, I think, and then we have a ton of clinical trials as well, and I'll sort of speak to that later in the talk. Now, beyond the numbers, what makes us special, I think, is really the people here. And so I wanted to take a moment to really kind of highlight different research groups. I didn't have time this morning to really speak to everyone's research, and you would do it much better justice than I can. But we do have these research spotlights that I sort of solicited from everyone. And so a huge thanks to Linda Banzi for putting it together, to Nurlima and to Amanda for helping with this process. I have a draft version here that Linda actually just dropped off this morning, and I hope that this is a draft version. It'll go out by email, that all of you who haven't contributed yet will contribute to it. We did have to copy edit some of it, so please proofread. But this is just an incredible document that I think I'm so proud of. And so just to highlight some of the things that are in there, I just pulled the list of people who have so far submitted. So we have 30 submissions so far. If you haven't submitted, please do. I'd love to highlight any academic work, whether it's NIH funded, industry funded, whether it's med ed focused. We really want to just highlight the breadth of all of the work that's going on here. And then I think just to pull the first three that came off, because I think this again is sort of like a concrete example of how much cool work is going on. So the first one is by Arti, how do cancer therapies cause cardiovascular toxicity? The next one is by Brett Carroll, what is the role of catheter-directed therapy for the management of acute pulmonary embolism? And then the third is by Dan Cruz, which circulating metabolites and proteins are associated with incident coronary heart disease in African Americans? I mean, just think of the breadth of the work that's going on here. It's just incredible. And these were just the first three. So please submit, and I'm excited to have this to distribute hopefully sometime in January. Now, because I can't highlight everyone in this talk, I will highlight certain groups. And I think what I want to stress is, again, what's special about this place, I think, is really sort of this multidisciplinary and really uniquely collaborative approach. And I think what we really have is research that spans experimental models to human physiology, molecular profiling to clinical trials, and clinical research to really hospital-based care and outcomes. And I think the fact that you have all of these here is really incredible. And I think the fact that people are uniquely sort of collaborative and working and synergizing across disciplines, I think is something that's pretty special. So just to highlight different groups, this is our basic translational group in CLS. You can see, of course, all of you know. So I'll just highlight some of the big themes. So RT is, of course, working on cardio-oncology. Mark is really interested in dyslipidemia. Dan Cruz is looking at racial and ethnic differences in cardiovascular disease. Rob is looking at large molecular profiling to understand cardiometabolic disease. I'm working on HFpEF. Peter King is looking at ischemia reperfusion injury. Mike Mee is looking at metabolome profiling to understand lifestyle risk factors. Anjali is looking at high throughput chemical screens. Eric Osborne, intravascular imaging. Jeremy is looking at exercise physiology. Alec is looking at endothelial dysfunction. Usman, genomic profiling. So again, just highlighting the incredible breadth of research here. I think the other sort of center that I wanted to highlight is really in cardiovascular imaging. This is, of course, headed by Warren Manning, who's had a longstanding sort of interest in and track record of looking at non-invasive cardiac imaging for detective cardiovascular disease. Reza has multiple R01s looking at quantitative imaging methods to enable translational research. And I actually pulled a figure from one of his papers that I thought was fascinating. They're actually doing exercise studies in the cardiac MRI scanner, and they're looking at using AI to really get rid of motion artifact to be able to sort of read scans while somebody is exercising. So I think this is really cool work. Jordy is looking at imaging registries with respect to valvular disease. And Connie is studying epidemiology of subclinical cardiovascular disease across large population-based cohorts. I think the other thing that's exciting here is that we have our cardiovascular clinical trials organization. This is really led by Jen Kaufman and Don Cutlib. We have our clinical research council as well, that's shown here. And I think some numbers here to pull, again, this is sort of staggering. We have 15 PIs across disciplines, including interventional, structural heart, vascular medicine, EP, heart failure, and preventive cardiology. So this is really going on across all of the sections. I show Jen's team here. They're really incredible, and they're supporting so many trials. So we have 16 open trials, 3 pending activation, 12 really in the follow-up phase, and 12 new studies planned in the new year. So a lot of activity here. In the past year, they've consented 235 patients, and 110 were actually enrolled. And some of the newest trials, just to highlight, there's a trial looking at inclisiran in hyperlipidemia led by Mark Benson. Eric Zemsky is looking at renal denervation and uncontrolled hypertension. Andre Davila is looking at atrial fibrillation and left atrial devices. So I think a lot of really cool trials that I just sort of picked and highlighted some of the new ones going on. Of course, we also have the 10,000-pound gorilla, the BAME Institute with leadership from Mike Gibson, and lots of involvement from BI investigators. I think BAME is really incredible. I think there's so many trials that are really connected there. Some of the ones to highlight are Heartline, which is Apple Watch to detect atrial fibrillation, and then really the first ApoA1 infusion in humans post-MI. To look at lipid therapy. And just by the numbers, this is again staggering, over 1,000 projects since 1993, over 100 FDA submissions and approvals, over 80 FTEs, and over 7,000 sites that they're connected to in 50 countries. So really an international powerhouse and presence. And then lastly, I think all of you have sort of seen the incredible success of the Smith Center. I'll just sort of briefly highlight, this is of course led by Bobby and Kazi, and some of the investigators and interests are highlighted here. So Bobby, of course, is very interested in cardiovascular devices and therapies and clinical trials and observational studies. Kazi is looking at really health economics. Dan Kramer looking at use of medical devices and really the ethics around that. Jordi, again, looking at imaging and valvular disease. Eric, looking at comparative effectiveness of coronary vascular therapies. Rishi, really looking at health disparities. Anna, who's sort of the newest faculty member, looking at disparities in care for peripheral arterial disease. Brett, looking at vascular disease. And Peter, of course, with a longstanding interest in arrhythmias. And so, how do we sort of think about pulling people together across these disciplines? I think a lot of it is already ongoing, which is really exciting. I think I'll just highlight some of the synergies. Arti and Mark are working on basic science and really informed by human observations out of Rob's lab and in collaboration with Rob. I think there's a thematic sort of synergy around human physiology and cardiometabolic disease that I'm really excited about. I think there are ways to push forward with respect to data science approaches to better classify clinical endpoints in the EHR. I think certainly cardiac imaging across disease states are potential synergies across many groups. And then I think sort of one prime example is really research in vascular disease that has spanned basic science, clinical research, and then large outcomes registries. So I think these are sort of some of the ongoing synergies. How do we sort of look forward? I think one thing that I'd love to sort of encourage is bringing people together around cool science. And how do we really do that? I think it's already happening organically. I think one way to do this is perhaps to have sort of thematic focus. And that's something that Rob and I have talked about in CLS. And then this is an idea that actually Kazi came up with, is really instituting a research brown bag lunch where we get together just very informally and talk about each other's work and really get to know and dive deep. And I think this will hopefully lead to future collaborations and just ideas. I think some of this is serendipity, but sort of creating the opportunity for that moment to occur, I think is something that I'm really excited to do. And so we are sort of launching this in January this coming year. I think the other way to really bring people together is there's a recognized need for sort of computational expertise that really spans across research disciplines. And so I think I'm excited to really be thinking about expanding that with respect to potentially having a faculty member that really has expertise in advanced biostatistics, bioinformatics, and then potentially having mentees that are paired that have computational expertise with clinical fellows, for example, that can really sort of run and sort of take off with a specific project. So those are all sort of initiatives looking forward. And then lastly, I think I'm really excited that Nora Lima Grandison has joined us as program director. I think many of you have had a chance to meet with her. If you haven't yet, please do reach out. And I think that she's been just an incredible force to sort of bring people together, to really listen, to figure out what are the concerns, how do we improve, how do we sort of build upon what's already here. And so in terms of the ecosystem, we're supported, of course, by so many people, and just wanted to acknowledge that in addition to Nuralima and Joanne, we also have incredible administrative support, as well as grant support. And I think all of these things kind of make us a richer place, and helps us sort of do all of the work and kind of get together. I think in terms of sort of infrastructure, we of course have many seminars that sort of, again, bring people together. And I think one initiative in the future to really foster sort of a start in clinical research is sort of thinking about putting together a research operations manual. So that's something practical that Nuralima and I are actually working on, really to develop a resource manual to support investigators in the conduct of research. And this is really sort of a how-to manual that's going to be the go-to document for new investigators starting out. Who are the IRB contacts? How do we actually sort of practically go about this? Who are the grants and contracts people to contact? What kind of questions can we help with to really sort of operationalize and make the process very smooth? So in the last few minutes, I'd love to sort of turn to something that I'm most passionate about, and that's really mentoring. And I think that we think about mentoring really as a team sport. And I think about this a lot. I think that we all sort of benefit from having a diverse workforce and different perspectives around the table. And people talk about the leaky pipeline, and that, you know, really there's attrition at every single stage in training of really great people. And how do we actually sort of support people the right way through their time in training? And I think we realize that we only see a minority of individuals who might have had fantastic potential when we get to sort of the more advanced stages of even being a faculty member. So how do we actually sort of fix this? How do we address the leaky pipeline? I think what's incredible here is that this is already happening. And so I'll highlight some of the mentorship programs that really span all the way from medical student all the way through faculty. So there's the Cardiology Summer Research Training Program. This actually was started recently by Rob and by Pablo. The purpose is really to provide summer research experiences to high school students of underrepresented in medicine backgrounds. And they just had their first class come through of 4 students. And I hear from Rob, it was really incredible to have them really join labs and really sort of have this immersive experience over the summer and hopefully spark their interest later on. I think the other sort of incredible opportunity is really the fellowship that was started by Peter's family, the Joan and Marcel Zimmetbaum Fellowship in Health Outcomes, Equity, and Policy Research. The purpose was really to support training of students from backgrounds traditionally underrepresented in medicine in partnership with the Smith Center, and leadership really is by Peter, Rishi, and Bobby. And I think this is just an incredible initiative. The inaugural recipient was Ashley Kralbazi, and then the current recipient is Chantal Henry. So I think that this hopefully will continue to grow and has been an incredible addition to the Smith Center as well. I think from a residency perspective, many of you actually have worked with fellows from the International Research Initiative. So this is a really cool program that's headed by Pablo and by Arti to support aspiring scientists really from around the world who have the desire to explore and nurture their interest in scientific research. And I've listed sort of the current fellows here. So we have Laura, who's working in the heart failure group with Will and Rashad, Ivan, who's working with Alec, Santiago, who's working with Anjali, Alvaro, who also is working in the heart failure group with Will and Rashad, Mahesh, who's working with Jeremy, and Franz, who's working with Usman. So really incredible fellows that are spending time with great mentors in the lab for a full immersive year. And then some actually stay for a second year as well. I think from a residency perspective, the other program that I am really excited to highlight is the Women in Cardiology Coaching Program. This is headed and really was the brainchild of Megan York, in addition to Inba Robber and Alyssa Corley. And really what they recognized is there's typically sort of a high interest among women residents in cardiology, but that quickly sort of drops off. I think partly maybe because there are a lot of conceptions that might not be true, or there's just not connection with female faculties in cardiology. And so they really set forth to increase the number of women residents deciding to go into cardiology. And what Megan does is she matches interested residents with cardiology faculty as part of a coaching program. So far, she's had 37 participants. 16 have graduated, 12 of them are currently in cardiology fellowships, 2 are applying, and 2 are currently not pursuing cardiology. So I think this has just been an incredible program to take forth. And what I would say is that Megan's been incredible in her leadership. There have been so many interested participants that I think actually all of the women cardiology faculty are engaged in this program currently, which I think is really just incredible and speaks to sort of the investment again in really trying to sort of mentor some of the trainees coming through. Of course, for our fellowship program, we have lots of support, and this is of course headed by Joe and by Rishi. There are many touch points throughout the fellowship. I'll just highlight the panel, which just happened. I think it was coined maybe by Leah, I'm not sure. But basically, we're now doing an annual meeting with all of the current F2s and F3s, F4s who are pursuing clinician investigator pathways. And I think this is just an opportunity to sit around the table to provide fellows with a unique opportunity to meet with all of the program leadership, to really review and provide guidance on their clinical education and or investigative pursuits. And I will see what the feedback is from the fellows. We just had all of our meetings with the F2s, and I think they went okay. Nobody left the room crying, so we're good. But I think hopefully this will be another fun way to really engage and to think about career perspectives with different people around the room, and to figure out how we can best support our fellows as they go on to pursue whatever their goals may be. I want to highlight the T32. This was renewed this year, so we're really excited about it. The purpose is really to train young researchers committed to careers in investigative cardiology. And I think it's very broadly written, again, really to speak to the expertise that's across this institution around big data, statistical modeling, bioinformatics, and integrative omics. So this really honestly can sort of match with any of the mentors that are here. This is directed by Murray Middleman and co-directed by myself with leadership from Rob and also from Bobby. And I'm really excited to announce the first class of fellows. So Jacob Barber is MMT in Rob's lab. Jing Liu is working with RT. And then we have 2 of our current second-year fellows who are going to join the T32, Leah, who's going to work in my lab, and Luke, who's going to work with Rishi. So we're super excited about this first class of fellows coming in, and we're still reviewing applications, so others will be determined as well. I think from a fellow to faculty level, the other person to highlight is really incredible leadership by Anne-Marie Anagnostopoulos, who's the Director of Recruitment and Advancement for Women Fellows in Training. I think one of the things I got to participate in was during fellowship recruitment sessions. Anne-Marie actually puts on sessions for all of the interested women applicants. And I'd have to say that there's incredible participation from all of the faculty as well. And this is just sort of an informal forum, again, to answer questions, to kind of chat about what it's like to be a cardiologist here. And I think there are many other sessions sort of longitudinally that Anne-Marie is leading. So I think, again, an opportunity to really engage and bring people together. And so I would say that this is sort of the last, as we think about the transition to faculty, how are we doing? And I think this is really just incredible. We have 10K awards. Again, this is like unheard of, I think, in any other institution. These are just the current K awardees with their mentors. I do realize all of the mentors are named Robert, so we need to change that in the future. But I think just incredible to sort of think about all of the physician scientists who are doing incredible work with the mentorship shown here. And so where does that leave us? I would say that actually we're doing really well when we think about mentorship through this pipeline. I think one of the initiatives that I am excited about taking forward is really thinking more closely about sort of what happens at the faculty stage. I can see that very early on, as a faculty member, when I first transitioned, I felt really lost because usually during fellowship, you sort of get your schedule, you know exactly where you're supposed to be for 365 days of the year. It's very prescribed. And then I think once you transition to faculty, it becomes much more nebulous. How do you sort of make up your day-to-day life? How do you figure out what percent clinical volume you want, how much research you want? How do you figure out how to set up a lab? How do you figure out how to sort of negotiate with collaborators? And so those are all sort of questions that I struggled with early on. And so what we're really launching again in January is sort of a faculty early career mentorship program and the goal is really to provide early career faculty with the opportunity, again, meet with a mentorship committee to kind of review and identify career goals and to provide guidance and support in various academic and investigative pursuits. I would love to ideally sort of have everyone go through this just to normalize it and to also get to know what people are really excited about doing and what people are thinking about doing. I think we're going to start small and then sort of expand from there. So looking forward to sort of launching that soon as well. So I think I'll return really to the vision and the mission. I think the vision really is to get us to a place where we conduct impactful cardiovascular science really centered around the health of our patients with the clinical piece really at the center of it. Our mission really is to enable diverse and transformative discoveries within and across disciplines. And I think we want to really leverage and play to our strengths, including sort of the breadth of multidisciplinary science that's being done at a really high level and caliber, to really leverage our diverse ecosystem, and then to really continue the dedication to mentorship and really training the future next generation of leaders in the field. And so I love the Japanese concept of ikigai. I don't know if you guys know what this is. This is the concept. So iki means life and gai means worth. And it's this concept that you should be spending your life's purpose really dedicated to what you're passionate about. And so it's sort of the conglomeration of what you're good at, what you love, what the world needs, and what you can be paid for. And so when I think about what we have here is we have, you know, really rich scientific discovery. We have an incredible community and environment. We have mentorship across all of the career stages that all of us are dedicated to. And this is all through the lens of really diversity and inclusion. And so I think our goal is really to sort of be in the center of it, similar to this concept of ikigai. So I'll sort of stop there. I think I wanted to acknowledge a couple of people. First, to Rob, I think that it's incredible that he's here post-op day 0.5. Thank you. Thank you for believing in me. And you're sort of the best boss that I can imagine. It's been really a great partnership. And I've really loved sort of the transition and this past year and getting to work with you. I think to Peter, again, also in believing in me. And I think in many ways for setting the tone of the culture of this place. I think it's really special. I think Noralima, I'm super excited that you're here and that you're sort of helping move a lot of these efforts and initiatives forward. To Amanda for sort of helping manage the day-to-day stuff for me. I'm so grateful for my clinical family. I can't sort of overstate that. I'm so grateful to work with them from a clinical perspective. And then I think most of all, grateful to my lab. They all came with me, which is incredible. And we're up and running with patient-oriented studies. They've done an incredible job sort of getting to know research operations in a new institution. And we're super excited to kind of interdigitate with all of the other research groups here. So I'll stop. I know we have some time for discussion and questions, so would love to really make this more of a conversation from here on out. So thank you.
One, that was excellent kind of overview of everything. One, kind of moving forward, very successful in our lecture series, where different faculty members will come, not to talk, but basically talk about their research in the lab and have various faculty members.
Yeah, that's a great suggestion for those on Zoom. I think Joe was bringing up that there's an opportunity for potentially to sort of incorporate different faculty members coming through the fellowship boot camp. I think that's a great idea. I always am so curious about career paths because no one's path is straight. And I feel like just having different faculty members from different backgrounds with different perspectives come through would be really great. Is there a question on Zoom, Dr. Rusty?
Yes, I was interested in your finding that the stiffness of the heart and vessels is greater in women than in men. Have you thought about studying men who are taking female hormones?
Oh, interesting. That's a great question. We have not thought about doing that. We know that actually women have greater arterial stiffness, both in health and disease. We don't really know why. Part of it may be body size related. So, women have smaller hearts and smaller blood vessels in general. And so that might be part of it. I do think there are probably other biological underlying mechanisms that account for those differences that are as yet not known. What was really interesting actually in our study of MGP heterozygous mice is that the mice that had increased arterial stiffness were actually the female mice, not the male mice. And so I think there's a lot of work still to be done there to kind of understand why these sex differences exist. So great question. Rashad.
Jen, fantastic talk, and obviously we love having you as part of our clinical group. So thank you for all of the insights. Great. You mentioned in the beginning sort of the other big change over the last couple of years has been obviously the COVID pandemic, and how do we sort of position ourselves to understand how that will impact the diseases that we treat on a daily basis. And have we thought about also, reaching out sort of across, other specialties within medicine, sort of form those teams to position ourselves well to be the people trying to understand how this will impact.
Yeah, that's a great question. So just to repeat it for people on Zoom, Rashad was asking about sort of how do we position ourselves sort of post-COVID pandemic, recognizing that there's so much increased cardiovascular risk that's occurring. It's a great question. I think there are probably many ways to sort of think about this and maybe move forward. I guess from a research perspective, we currently have a grant to look at post-COVID cardiovascular dysfunction, and we are actively enrolling patients. And we've partnered actually with Jason Maley in the post-COVID clinic. So they're seeing a ton of patients with long COVID, and actually their wait lists to get into clinic are now up to like over 6 months. So there's just like a tsunami of people with long COVID, I would say. So we've partnered with them in terms of patient recruitment and to really better understand implications of long COVID. The BI is part of the Recover initiative, which is a huge NIH effort to really look at long PASC or long COVID. I think that they're fully enrolled. This is with Janet Mullington, who's really the overall PI at the BI. And there's like a Boston consortium that brings people together. So the BI is part of the Recover cohort. And I know there's a lot of sort of deep phenotyping going on there. And then I do know also, like, I think through the Smith Center, there's a COVID grant sort of pulling and looking at cardiovascular outcomes post-COVID. I don't know, Bobby, if you want to say something about that. I actually don't know that much about it.
Yeah, we have a partnership with the American Heart Association. So we are their sort of long-term outcomes. AHA, COVID cardiovascular, right? Which has several thousand patients hospitalized with COVID. We actually have a paper that's sort of cycle right now that's not unlike the paper that you have long-term survivors of COVID hospitalization.
Yeah, thank you. But how we do that clinically, I actually don't know. I think what was sort of apparent through, I was part of some of the setup for Recover on the MGH side. And I think even just getting people in the same room in terms of sort of having neurologists, cardiologists, general medicine, endocrine, renal, because this sort of is multi-system, of course, was so interesting. So I think, but how to sort of roll that out clinically, I don't know. Short of, there is the long COVID clinic here. but how do we sort of interdigitate, or how do we engage as cardiologists? That's a great question. Rob?
So, Jen, that was a really wonderful collaborative talk. And just one comment about the clinical trials work. I do think, when I came here 5, 6, almost 7 years ago now, I'd say that there was a real learned defeatism at this entire institution around clinical trials. I really think that there's a lot of getting things through sponsored research programs. It was really quite fun. Jen's done a magnificent role helping with that. But I do think that over the last couple of years, there's been a palpable change with Todd Wolf coming along. So I would encourage people who who are new, who don't have that learned defeatism, that there are really a lot of opportunities there. And I think it's a much smoother shift than it was. And also you talk about all this great observational research, but basic observational research, large data observational research, it funnels into doing clinical trials. And that's the only thing, of course, formed by market surveillance and other things, human genetics, tell you about causal mechanisms. But I really do think that that's an area where we can really push the envelope down. And I think we're more prepared as an institution. Very helpful. If anybody comes into problems, please address them with Jen. They're really looking to expand.
Thank you, Rob. Kazi?
Jen, that was a fantastic book. Thank you so much. Your 4 years that I've never seen that. So really good.
Thank you.
As you know, success builds on success, and some ways been beneficiaries of that process. But it also means that people who didn't get exposure to research later in their career can be very intimidating to get the process later in life because they're competing with people who've done other work before on the way in. And so how do we create, I'm just thinking about this, how do we create opportunities for people who are further along and have not had exposure to research but want to explore whether that is full primary or secondary focus?
Thank you. That's a great question. So Kazi's question was around sort of success breeds success. And if you haven't had the experience or the opportunity to kind of dive into a research project, how do we sort of encourage that at all stages of career, not just sort of early on? So that is actually like personally resonates with me. I didn't really sort of think I was made to do research until a 3rd year of cardiology fellowship. And I think what was formative for me was a mentor who I got to work with that really sort of changed my entire perspective on things. So I think, how do we do this? I think with great mentorship throughout all stages. I do think providing people the opportunity to explore is something that I'm a huge fan of. And so whether we do that through the panel during our meetings with fellows and trainees, perhaps we can build this also into the early career mentorship meetings. Maybe there are research projects that come out of this that, are really motivated clinically by a really interesting and important question. And can we sort of support that in the right way to have people really take a deep dive and try to answer that question the right way? I think there are probably many opportunities there as well. Yeah. Mike.
Jen, that was great.
Thank you.
Somebody doesn't do a lot of research and just sit at home, your work and what everybody else does. But we all but some, certainly the help me about the IRI.
Thank you, Mike. Yeah, I think that the vision really is to support academic and research pursuits across whatever makeup of career we all have. I think that your clinical expertise really and questions motivated by that are the most important ones, right? I think that so really thinking through how we support that and whether that is by computational expertise and really pairing, right, sort of someone who has a biostatistics background with sort of a clinical person is sort of, that I feel like is potentially one way to kind of make that work, because I do think that we need to be informed by what are the clinically important questions to ask in the first place.
And I
So.
think you come across
Yeah. Absolutely. Thank you, everyone.